I picked up the handset, so hopefully it'll be a little bit clearer. I apologize for not being there, but such is modern travel. It's been a frustrating night trying to get there, but happy to be there. I know it's always easier to have a visual, and I don't think I've met any of you on the panel there, so I'll just let you know I'm 6'3", 200 pounds, 2% body fat with wavy blonde hair. So if you can imagine that. Actually, I appreciate this opportunity to talk to you today. Representing Johnson County, we're a small health department, have a jurisdiction of about 133,000 people, but we're not strangers to disasters here. We've had a tornado in 2006. We had a major flood in 2008. We experienced H1N1 in 2009, 2010. We had a landfill fire that had the lining of the landfill was shredded tires, which caught on fire and burned about 1.5 million worth of tires here. And then flooding again in 2013. So we've got a little bit of experience getting proficient at working and mitigating disasters. The topic of long-term recovery, though, may be a little different when we get to that. So just to start off, I know the questions were about funding, et cetera, and we really had no direct contact in terms of getting funding from FEMA here at the local level. We've worked through our county system, and the county has been the conduit for working at FEMA. If we go to the second slide, some of the things we do when a disaster is prepared, the question was, what are some of the funding sources that come through? When a disaster strikes and we respond, we work within our approved budget. So we divert personnel, whatever it takes to meet the public health needs and to fill our responsibility at the Emergency Operations Center in our ESF 8 response. One of the caveats to this, and I'll talk more about it in the recommendations, though, is when you're thinking long term, my department, I only have 37 FTEs, so I've got 37 people, and most folks would think, okay, you've got 37 people to respond. When you look at the budget, how my budget works, though, about half of those really is what I would put in the discretionary category. In other words, what is funded through my county sources. The other half are grant-funded folks. So my WIC program, my maternal child health program, the community transformation or health promotion programs, those are generally federal dollars passed through the state. Some state funds might be in there at the local level. So if you're thinking long-term, then you understand that FEMA reimbursement or coverage for your response, they're going to look at those. You have your county resources, and so we're only going to look at the overtime expenses. So I've got clearly half of my staff that I would have to work full-time and then work overtime on the response if I'm going to expect any sort of reimbursement. The county does have resources. Counties are required to have reserves to use in times of emergencies. That we can put that into our budgets through an amendment process. Counties can also essentially borrow from future tax revenue by issuing tax anticipation bonds. We do have experience, what I put in the category of non-FEMA emergency allocations during H1N1. There were a large amount of money, actually quite a bit of money, that was allocated that we received for our response. We used that amongst our partners, our hospitals and clinics, and our other partners, some of our private partners in visiting nurses to help run and staff clinics. Also, the state has emergency funds, and I think you've had other speakers who talk better, more knowledgeable about that. But they do have resources that they can allocate to us, and they've also diverted some of the normal resources. Going to the third slide, how we make decisions. At this point, I'll just kind of say I'm just representing Johnson County, Iowa. there's 99 counties in Iowa, each with their own health department, and we also have 2 city health departments. We have a saying in local public health, it's when you've seen one local public health department, you've seen one local public health department. The structures, there will be common things in our structures, but there's a wide variety in the types of programs we have, the types of personnel and skills and assets that we can draw upon. I would direct you and recommend that you talk with our partners at NACHO, the National Association of City and County Health Officials. They do a profile of local health departments every year, talks about the structure, the different programs and funding sources. They would be a great resource, I think, to help you in some of the background. But generally, we have a Board of Health, which is an appointed board, but they give broad executive authority. They're usually not involved in the day-to-day operations or day-to-day decisions where we're going to put people. They'll invest that in an executive on a day-to-day basis. When there's an emergency and we go into the incident command system, that authority is even enhanced. Decisions need to be made quickly. There's not always time to assemble a board, a volunteer board, get together to make some decisions. They are generally there for looking at oversight of how it's managed. They'll be looking over our fiscal affairs as well. But generally, there's a lot of trust put in place between the executive of the health department and that board. Communication is going back and forth. If they need to trust that the executive is going to touch base with them when there's a large policy decision that needs to be made. And again, that's mostly enhanced during the response and short-term recovery phase. That's how we work internally. Externally, we take our part at our Emergency Operations Center and fulfill our role in the ESF8. We are the subject matter experts. So when the decision makers in the disaster get together and there's a question about health, and we have pretty good relations. We have established some real good working relations with all our partners. They'll defer to us. Or if we see something that's going on, we have authority. We'll chime in and say, why are you doing this? And here's a different way to go. Our EOC operates, it'll be open, it'll be running at full scale during a disaster, and as things quiet down, various sections of that will shut down. But we've left our EOC or sections of it open for quite a bit of time during recovery. So we'll still be in touch with our partners, and decisions are made there through the incident commander and the team that's assembled. During our long-term phase, it's interesting, the questions that were put in, because we've been so focused on, when a disaster happens, our immediate thought is, the immediate safety and health, monitoring what's going on, what do we need to do, but then it's as previous speakers have mentioned, getting things back to normal. And as soon as the waters recede, or there's no more disease going around, or we've administered all the vaccine, it's really let's get back to business as usual. And we really don't have a plan or a thought about what are we going to do now long term in assessing the community. Are there any lingering problems going on? So that's I don't know if I even got that in the recommendations, but that's something that we need to work on here. In terms of funding, if you go to slide 4, you'll probably see a blank page. I always try to insert a little humor. If you click it again, you should get anybody who works with emergency plans sees this page intentionally left blank. Funding sources for long-term public health recovery activities, at least at the local level, this is an area where, are there long-term recovery funds available? And again, I think that it points to, at least in our situation, are there things from the 2008 flood that we should still be assessing? Now, we did have, in that incident, we had many ad hoc, private, we had a COAD back then, communities organizing against disasters. So we did have a community coordinating committee that was provided oversight for the private funds that came in to help in the disaster recovery. We did have FEMA representatives there who could provide input. So if a family was seeking assistance, the FEMA representatives could provide input to say, well, they have so much available to them through these other disaster areas. But that group would discuss who was in need, had they exhausted all their other resources, did they have insurance, and allocated money based on the needs. I'll just get to the last slide here because there's a lot of other things that we could say, but I'm sure there'll be some questions. Some of our recommendations, though, is one, fall back on the preparation, planning, structure, relationships that you've developed during the planning processes. That's been preached and preached, and it's been exercised here. I can't say enough about it, that at least in our town, in our community, in Iowa, we're considered a large county. In a lot of states, 133,000, they would think maybe that's a rural community. But building up those relationships, knowing the first names of the people who head up emergency management, law, fire, other response, and even our elected officials was so very useful. Making full use of our public-private partnerships. I think nationwide they're referred to as Business Emergency Network Services. In Iowa we call it SIP. And I'm going to forget what that stands for, but all of our private companies, somebody may have some equipment, somebody may have some special skills. They've registered, they're organized, and they offer services in response as well. Here's one that I want to come back to, though, because I mentioned, I've got staff on WIC, maternal child health, public health and prevention grants, who really at a budgetary level, even in a disaster, I really don't have access to until I've worked them more than 10 hours a day or 40 hours in a week. And it just seems like there should be, I know there's been talk about this, but there should be an easier way so that I don't have to stop and think about, okay, I'd really like to use Becky downstairs, but gee, am I going to be able to pay? Is there some other way to use this person in a disaster? And so if there were some way to allow those grant funded people to work in their grants, and we could report it back on the grant. Yeah, I spent a week responding to the disaster, but I'm still going to turn that time in on my WIC timesheets and get reimbursed on it. If there could just be a little more open door policy and look at how that can. Now, if that's not possible, re-examine the overtime only and the direct forced labor policy restrictions in FEMA assistance. So, maybe I could look, even those employees or county employees working regular time, if I can say, but that's a grant-funded position and I'm diverting them, so would this be reimbursable? I think would help a lot. Also in that, considering of block grants or supplemental allocations. So now, I want to do some long-term strategy. Maybe there's some additional information I need to learn from my maternal child health or WIC or other populations. That takes additional time, additional training, some additional resources. So like I say, we get things back to normal. Buildings are built back. We've addressed mold. We've worked with the folks who have private wells or septics. We've worked with the restaurants that were flooded. They're back and working now. And when that happens, we kind of get back to regular business. No special surveillance on are there any lingering problems, because there probably are. So that's kind of what I had to say. Hopefully that's helpful, and I'll be glad to answer any questions.
Well, terrific. Thank you, and stay standby. So let me just